Hi, my name's Morgan. I don't know a lot of you, but I see some familiar faces. I work here at North Kansas City Hospital. I'm a critical care educator. I've worked here for 9 years. I've been in critical care for 10, I think. Been a nurse 13. I've been around for a minute, I think, it seems like, but it also feels like it was just yesterday. But I am going to speak to you about cardiac stuff. Does anyone love cardiac? Yay, yay. I didn't expect any hands from a med-surg group, so I appreciate that. I love cardiac. I worked in the cardiac ICU. That was my home. That's my true love. So I feel very passionate about it, and it was kind of fun when I was working on this last night before my 8-year-old went to bed. We were sitting there looking at the anatomical heart and going over the structures and what it all does, so I'm, conditioning her early for what her specialty is going to be. So we are going to talk about a few things. First, we're going to go over basic A&P. I know all of you have graduated nursing school at some point in your life, because otherwise you wouldn't be here. But we're still just going to do a little brief overview. We're going to talk about cardiac output and what all the components that make that up. We're going to talk about electrolytes and labs. We're going to talk about all these different cardiac disorders. And we're going to talk about some life-threatening arrhythmias, which is apparently somebody up on the 8th floor is having right now. So, okay, basic cardiac A&P. You guys so happy to be back in school right now. We're going to start basic anatomy of the heart. There are 4 chambers. I think everyone probably, hopefully, already knew that. We have 2 atria, 2 ventricles, a left and a right. There are 4 valves, AV valves. They're the tricuspid and the mitral, or you might hear the mitral called a bicuspid. And then we have our pulmonic and aortic valves. There are 3 layers to the heart muscle. So there's the endocardium, which is the very inner portion here. And then you have, the myocardium, the actual muscle. And then we have this little epicardium with this little pericardial sac here to cushion the heart. I apologize. I have like notes on all these slides and I can't see them in the way they have this set up. I'm so sorry. Because otherwise I'll just be up here fumbling real bad. And you guys will be like, get this lady off here. Current slide. There we go. That's what I needed. Okay. Does anyone know, we're going to talk here about going with the flow. How does the blood flow through the heart? Does anybody know this? Can just rattle it off? We're going to go through it together. When I was in high school, we had this little option program where you could go and learn how to be a CNA, and they did all this extra training, so the second half of the day in your senior year, and my teacher would not let anyone graduate until they could recite this from memory, on demand. So maybe that's where my conditioning started. I don't know. So where does the blood enter the heart? Who knows? How does it get there? We start with the vena cava. So those big, huge veins there are going to take the blood. Where is it going to dump it into? That first chamber. Right atrium. That's right. Good job. Then it's going to go through a valve here, the tricuspid valve. That's going to dump it into where? The right ventricle. Yep. So we've gone through the right side of the heart. What does the right side of the heart feed to? What system? Lungs. Our pulmonary system. So to get there, we're going to have to travel through the pulmonary artery. And there is, a lot of times people don't really talk about it. It doesn't tend to be a huge problem child really with the heart in comparison to a lot of other problems, but the pulmonary valve, the pulmonic semilunar valve, is going to be our gatekeeper to the pulmonary artery. Then we're going to branch out, go pick up some nice oxygen, right? So we got to carry that on to the rest of the body. And then come back to the heart through these pulmonary veins. Fun fact, these veins are the only veins in your body that will ever have oxygenated blood, fully oxygenated blood, which is a fun fact, because usually that's arteries, right? So then that's going to dump into our left atrium. Where's it going to go next? We're going to go to the right ventricle. Our gatekeeper, our left ventricle, see? I'll tell you guys a secret. I finished this at 4 a.m. So I promise that I am a little coherent, but keep me on my toes. But to get to the left ventricle, we got to go through the mitral valve. So also the bicuspid valve. What's the difference? Why is one called a tricuspid and one called a bicuspid? The leaflets. Yep, the leaflets. So here, the leaflets for the right side, there's 3. On the left side, there's 2. So in our left ventricle, that's like our powerhouse, right? That's going to eject that blood to the aorta and feed the rest of the body. So this is like Big Daddy, real important. To get to the rest of the body, though, we have to go through our aortic valve. And then we're going to our aorta. What's next? Everywhere else. The body. Okay, so I did spend an unnecessary amount of time last night trying to figure out how to add in sound clips, and I never figured it out. But I was going to put a Megan Thee Stallion clip in there. The body. Sorry. I try. So another little visual here. I like this little road sign here, and like slow down. And then it has little lungs where it's going to go pick up the oxygen. Why do we care about our cardiac output? Why do we care about the blood traveling and getting to where it needs to go? It's got a big job, right? It's got an important job. It needs to carry our oxygen, which all of the rest of our cells need to live, work, function. It's going to carry nutrients, hormones, electrolytes, all the things. So we really need it to function optimally. I thought this was funny. You're under arrest for not being able to pump efficiently. Cardiac arrest. All right. Cardiac output. Who's heard of cardiac output? Probably not a huge focus in the med-surg world. We talk about it a lot in critical care. We have all these different ways to measure it, but the concept's still important. So cardiac output's made up of 2 things, your stroke volume and your heart rate. So stroke volume times heart rate is what gives us our cardiac output. And our stroke volume is made up of 3 things. We just gotta keep breaking it all down small. Okay, so preload, afterload, and contractility. Did anybody go over those in school? Yeah. Did anyone get it in school? Because I did not. I was like, I don't know what they're talking about, and I really hope this isn't on NCLEX. Just tell me what I need to know for NCLEX. So cardiac output, it's going to be driving our blood, driving that hemoglobin, driving that oxygen everywhere we need it to go. So we need to maintain it, keep it in an optimal space. You don't have to memorize all these numbers. Just a kind of a frame of reference. So we said cardiac output is heart rate times stroke volume. Stroke volume, that's how much blood is ejected from the ventricle with each beat. You guys all know what heart rate is, yes? Okay, good, we're on the right track. Within that stroke volume, I said we have 3 things, preload, afterload, and contractility. We're gonna break each of them down a little bit here and talk about them a little more. Preload is really going to be referring to, and you're going to think about volume when you think of preload. Afterload, we're going to think about resistance. And those 2, I don't know why, but it was for the longest time so hard for me to wrap my mind around. I was like, well, preload is before, but afterload is after. So is it the fluid after? It's like, oh, I confused myself worse. And then contractility, that's the easy one. Squeeze, right? I love this little graphic here. It's by this doctor on Instagram, if anybody has an Instagram. Chance to say most people do. But Doc Scribbles, she has a ton of really, really cool graphics. But I like these little guys here. So preload, that's our fluid. He's going off a diving board, filling up that right ventricle. And then we have our guys here for contractility, trying to squeeze. And then our resistance, our afterload. And then this guy's running away, the heart rate. So there's a few analogies that people can use to remember all these components. My favorite is the water bottle. The slingshot one's kind of popular. We'll talk about both. But so we said preload is our volume. That's that volume that's going to fill up the ventricle. It's going to stretch out that heart muscle, and that's what's going to be flung out and moved along in its path. So if we have a water bottle, we'll say I have Smart Water or whatever, Essentia, whatever. We have a water bottle, the opening is like standard size, right? We're gonna start filling it up here at a faucet, so that fluid going in, that's our preload. And the end diastolic volume is what EDV stands for. That means that ventricle at rest, right before it's gonna contract, that volume that's in there, that is your full preload number. So your end diastolic volume, that's your preload. So that fluid, that water, that blood, whatever, your Gatorade, whatever bottle you have, that's preload. Then we're gonna come in and contract, and we're gonna squeeze the water bottle. Does anyone have young children? And as soon as you give them like the high C pouch, it's just everywhere. I'm like, just don't squeeze that. So contractility, we're gonna squeeze that bottle. And then all of that preload's gonna go out of the opening. The opening represents our afterload. It's that resistance that the heart has to overcome to get that fluid where it needs to go. So our afterload is anything that's in the way, any resistance that's gonna make it harder or easier for that fluid to get where it needs to go. So, and then that squeeze is systole, that's that ventricle ejecting it. The slingshot analogy, kind of similar. So you have a slingshot. The preload is whatever you put in there that you're going to fling. So like a rock or a water balloon, something like that. My kid will find anything to throw. So pulling it back and stretching it is filling up and stretching and taking up that space. So that's our preload. When we let go, that's our contractility. It's going to get flung forward. And anything that would be in the path and in the way, so like these Angry Birds running into all these little blocks and whatnot, that's the afterload. Was anybody good at playing Angry Birds? I would get real frustrated. And then they made the Angry Birds movie, and my daughter wouldn't stop watching it for like 5 years. I'm like, okay, let's move along here. So I said we were going to break it down a little bit further. We'll talk a little more in depth. Preload. So we already said we're going to think about fluid. Really, truly, what happens is that fluid takes up space in that ventricle, and it makes those muscle fibers stretch out. And so naturally what happens is they snap back, and they're going to contract harder. Has everybody heard about the Frank Starling law? Two old dudes naming something after themselves. Okay, you guys, we got to come up with something we're going to call the Morgan law. So just let me know if you think of anything while we're here. That's my end goal for my career. I'm going to name something after myself. If these dudes can do it, I can do it. I can figure it out. So the Frank Starling law, these guys hypothesized, figured out, discovered, whatever, that there is a relationship between the preload and the contractility. So what they say is the more preload, the more volume we fill up that ventricle with, the harder the heart's going to contract and snap back to move it to where it needs to go. So if you think about a rubber band, you're going to stretch it, and the more you stretch it, the harder it's going to snap back, right? Up until a point. And then if we get too much preload, too much fluid, too much blood in there, it's gonna either snap, break, the rubber band's gonna get stretched out if we're doing it over and over and over too many times. So then you can be too far on their little curve and your stroke volume would actually go down because of more fluid, which feels very contradictory to what we're taught, right? Their blood pressure drops, so it's the first thing we're gonna do. Fluid, usually, typically. That's gonna be our first little Band-Aid until we figure out what's going on and fix the cause. What do you think could cause a low preload? So not enough fluid. Hypovolemia, dehydration, blood loss. Has anyone given their patient 80 Lasix and then come back and they've peed 4 liters and their Foley's about to burst? It's a real stressful moment, like so much panic, running, gotta empty this, it's gonna explode. Overdiuresis can cause low preload. Sepsis, so in sepsis we have these big fluid shifts and that's gonna cause a low preload. What about a high preload? Too much fluid. A lot of things cause that, right? Too much intake. If we gave a patient a ton of blood, a ton of albumin, if they've got a bad pump, they've got a bad heart, they can't contract. So CHF, it's not gonna move that forward. It's just all gonna hang out there and stretch and stretch and stretch until it can't stretch anymore. So, does a Starling law make sense? I have a little visual that I like. So, I kind of like to think of it as a balloon. So if we only blow the balloon up just a little bit of preload. I'm not strong enough. That's good enough. Man, my heart is not doing good. And we let it go. I haven't stretched it very far, right? So if I let it go, it's not really gonna go anywhere. It's just gonna plop down, right? Okay, let's see if I can actually do it though. I'm trying, my lung capacity is unwell. Oh my God, it's not gonna work, it's not gonna work. Okay, so now we've put more preload, more fluid, we put more stretch on the balloon. So now it's stretched further, so it should contract harder and go further, right, than our little one? It went further. What would happen if I sat up here? It would probably take a long time, obviously, because I barely could blow that up then. But if I kept blowing and kept blowing and kept going and kept going, it burst eventually. Or if I did it over and over and over and over, bigger, 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 it's gonna start to get stretched out and floppy and not effective. That's what the Starling law is talking about, basically. That's preload. Our next component, afterload. Look at this girl. Get it, girl. I love weightlifting. I was really excited when I found that. This is the resistance that ventricle is gonna overcome to move the blood forward. I think a lot of times when we think of afterload, we think of the left ventricle, but you have two sides of your heart, you have two ventricles. Afterload can be a problem for the right side too. We gotta keep moving it through each little pathway. So what would cause some resistance? What things would get in our way? I don't like things in my way. You can ask my friends. If I send them a Marco Polo while I'm driving, people get in my way, it's not pretty. So what could make our afterload higher, make it harder? Yep. High blood pressure, because then that's more pressure that heart has to overcome to get there, right? Stenosed valves, those gatekeepers, if that gate's not opening all the way, we're gonna have to squeeze through a little tiny gate. It's not gonna be pretty or easy. Or if that valve is floppy, things are just flying in and out and all over the place. What happens if someone has a chronically high afterload? That heart just has to keep working harder and harder and harder to get that blood out and overcome that resistance. Over time, the heart's a muscle, right? What happens to muscles when you start working out? Lifting. Yeah, gains, right? Except that's probably not great for the heart to gain muscle. So we're going to start to thicken here in these ventricular walls. But the thing about the heart is it's only so big. So where's the muscle going to grow? It's going to grow inward. Yeah, because it's not going to thicken on the outside and then flop up against that pericardium, that lining. It's going to grow inward. So that's going to start taking up space in that ventricle. That's less space that blood can be. So then we're going to actually be decreasing the amount of blood available because there's not enough space to put it, right? So those patients who have chronic hypertension, not treated, or maybe they don't know that they do, patients with those stenosed valves that aren't fixed, that heart just has to keep working harder and harder and harder to get that blood where it needs to go. Making sure I'm not forgetting to say anything because I'm really bad about just talking and talking. Oh, one thing. So I had somebody ask me, because I go over this a lot in my critical care hemodynamics class. And someone asked me, they're like, well, a low afterload wouldn't be a bad thing then, right? Typically a high afterload is what our problem is. High resistance is going to cause a lot of problems. And I was trying to think, and I was like, well, I feel very stumped right now because we don't typically focus on low afterload being a problem. I can find a problem though. And so I was thinking about these valves, these gatekeepers. So those floppy valves, when they're regurgitating, there's no resistance, right? There's nothing in the way. But that's going to cause a decreased afterload. So there's no resistance. But if that blood is just flowing here, there, and everywhere, it's actually going to probably back up because there's nothing closing that door and start to cause an increase in that preload so that fluid isn't effectively moving forward. Does that make sense? I'm just trying to find problems. I don't know. All right, our last component of stroke volume, contractility. This is the easy one, I think, personally. So how hard is that heart squeezing? How strong can it pump? Also, a term you might hear when we're talking about contractility is inotropy, or an inotrope is a medication that's going to affect our contractility. Positive inotropes, so that's something that's going to make it contract harder. My little meme down here is when you're at work and trying to stay positive. Everybody, every day. So positive inotropes, they're going to make that heart squeeze harder. So medications we use for that, dobutamine, milrinone, digoxin, those are all drugs we can give to make it contract harder. Then we have negative inotropes. They're going to decrease the force of contraction. Those are beta blockers, calcium channel blockers. Why would we want to do that? It's negative, right? Don't like negativity. So why would we want that to be the desired effect? What's that going to do for our body? What's that benefit? If it's not contracting as hard, it's not having to work as hard. So those negative inotropes are going to help decrease the work of the heart, decrease that workload. So maybe it's a heart that's under stress, maybe a heart that had a heart attack and is damaged and it needs to rest. We don't want to overwork it if we can help it. So that's what these drugs help with. This is kind of a given, increase the force of contraction. We're going to snap back harder, right? Really good for those CHF hearts. But negative inotropes can be a good thing, even though they say negative. They're going to help decrease that oxygen demand, decrease that workload of the heart. And we talked about how preload and contractility are related. So the more stretch, the harder we're going to snap back up until a point when my lungs explode trying to blow up a balloon. Then We're not going to be moving forward anymore. Okay. So we just went over the 3 components of stroke volume. How can we improve it? How can we affect it? There's a lot of things. We just talked about a couple of them, those inotropes. That's going to affect our contractility, either positive or negative. So that's going to, here, the little heart, increase inotropy. Ultrafiltration, so dialysis, maybe help take off some fluid, decrease that preload, going to decrease that work. This one is interesting, and I've had some doctors argue about this because why not argue about something? But most doctors, most physicians feel that BiPAP or CPAP, so that pressure in the lung, that positive airway pressure, helps force that fluid out. That forced pressure through there is going to help push that fluid out. So that's one thing that can help us. And then here, this arterial vasodilation and our venodilation, that's going to decrease that afterload problem, right? Those drugs. Going to make those vessels bigger, easier for blood to flow in and out and through. Oh, also, furosemide, this little kidney down here, going to decrease our preload, getting the fluid out of our way, right? Just love some Lasix. Sorry. Okay, question time already. That happened so quickly. So what does your afterload show you? Is it showing us the fluid in the right ventricle? The stretch of the ventricle whenever it's in systole and squeezing? The pressure that the ventricle has to overcome to eject the blood? Or heart rate times stroke volume? C. Ha, good job. You guys are all brilliant. Gonna do great. If someone has a high afterload, what might we do for them to help decrease that resistance? We're gonna give them vasopressors, vasodilators, or bolus them with some fluid. We'll give them some epinephrine, epi. Epi's always the answer, right? In ACLS anyway. Yes, yep, B. We're gonna give them some vasodilators, make that vessel bigger so that blood can move through a little bit easier. So what was our other component of cardiac output? We just went through all of stroke volume. What else makes up our cardiac output? Heart rate. This is also easy, hopefully. I think you guys know what heart rate is, so I won't give you, well, I did give you the definition. There we go, just in case. How many times that heart is beating every minute? How fast is it going? So just like contractility, we called it inotropy. Heart rate can be referred to as chronotropy. So look at this little guy sweating with his little sweatband. This one down here. This was a slide my daughter walked in on, and she was like, I'm confused. She's like, why is this heart shaped like this and this heart is shaped like this? And I was like, I don't know, they're both, it's just cute little picture. She's like, well, that's confusing because that's not what a heart looks like. I was like, okay. So if y'all didn't know, my 8-year-old wanted me to make sure you knew that the heart looks like this, not this. How is our heart rate going to affect our cardiac output? If the heart is beating super fast, going quick, 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 in theory, you would think that would probably increase our cardiac output, right? Because our heart rate times our stroke volume, if our heart's going fast, you would think that would probably increase it. The cool thing about our body and all of our body systems is that no matter what, it is going to do everything it can to compensate for some type of change. So when our stroke volume starts to fall, whether we're dehydrated or we have poor contractility and the heart's not squeezing well, any change in that stroke volume, our heart rate's naturally gonna try and compensate. So it's gonna speed up. It's like, oh crap, this volume fell down, I better pump quicker then to make up the difference and keep a balance. Unfortunately, that only lasts for so long until this guy is gonna fall over and pass out. So it's always gonna try and compensate. But these abnormalities in heart rate and rhythm, which we'll talk about rhythms here in a little bit, can actually cause more problems. So if our patient goes into an arrhythmia and their heart's beating super fast, quick, that's less time that those ventricles have to fill up with blood, right? So then there's gonna be less blood there to move. If our heart is beating super slow, it's gonna have lots of time to fill up with blood, but it's not gonna be pumping as fast, so it's like we got all this blood, but we're only ejecting it every couple of seconds, it seems like. That's not gonna give us enough perfusion either. So it's always gonna try and compensate, but we can still cause some issues here. What are some things that affect your heart rate, aside from going into an arrhythmia? What's gonna speed it up, aside from caffeine? Got an extra shot. Staying up till 4 a.m. and then waking up a few hours later, speaking to a group of people you don't know, might speed up your heart rate. Metabolic changes. Has anyone ever had a patient with a severe fever? Their heart rate sped up to compensate? That was like my first rapid response when I was a brand new nurse. I was so scared and I had no idea what was going on, and I didn't even touch the patient. I just saw on telly. I worked in a very small hospital. It was like 24 PCU beds, 8 ICU beds. And I was working on PCU at like 2 a.m. And all of a sudden, the monitor tech in the ICU calls, "Your patient's heart rate's 180. And I was like, oh crap. I'm supposed to have the answers now. I don't have anyone to turn to. Not really. The rapid response team came and they were helpful, but I like run in there and she's like, "Okay, what's going on?" She was a super poised, composed, critical care nurse. I was like, I want to be like her when I grow up. Oh. And she made me feel so calm, but I really was freaking out. And she's like, "So why does the patient have a fever?" I was like, "I don't know. That's why I called you. I don't want to call the doctor. He's going to yell at me." She's like, "Okay." And she walks up and she touches the patient. She was like, "Oh, that's why. They're really, really hot." And I was like, I probably should have touched them first, huh? That probably would have been better than freaking out. So those fevers, they're going to drive that heart rate up, those metabolic changes. Our fight or flight response, going to speed that heart rate up, or a vagal response, slow that heart rate down. Have you ever who's had a patient vagal? Oh, the worst, man. So fight or flight and our rest and digest, our sympathetic and parasympathetic nervous system. Our nerves, they're more than just about patients, although my kids, they really know how to find that last little nerve there. They're very important systems here, and they're going to have an effect on our cardiac system. Our sympathetic, so that fight or flight, that's like the heart's accelerator. When that fight or flight is stimulated, whoom, putting our foot down, pedal to the metal. Parasympathetic, that's kind of like our heart's brakes. Whoa, I'm going to take over. Let me slow some things down here. I thought this was cute. Those little fishies. If they band together, they could take on that shark. Sympathetic system, what's going to stimulate that response? What's going to make that go into overdrive? It could be anything, really. Anxiety, everyday stress. When that gets stimulated, it's going to speed up our heart rate. It's going to cause a whole bunch of other stuff to happen. We're going to release a bunch of epinephrine. We're going to release more glucose, whole host of things. Then our parasympathetic, when it gets stimulated, it's going to try and fix all the damage that fight or flight did. So I feel like the fight or flight's like Kool-Aid Man coming in, like whoop, kicking stuff over, all excited, making a mess. And then the parasympathetics can come in, clean up the mess, try and make things a little bit better. Our parasympathetic nervous system takes over naturally, more so at night. Specifically, I thought that was me. I was like, what did I do? Specifically, between 10 p.m. and 8 a.m. I was like, that's interesting. No wonder night shift feels a hot mess all the time. Man, their body's like, we're supposed to be breaking. We're supposed to be resting and digesting right now. Please stop running around. So, what questions do you guys have about cardiac output, about anatomy, about anything in the world? I'll try to find the answer. Before we go into talking about cardiac assessment, we want to just talk about those foundational concepts, because that cardiac output's what our ultimate goal is. How are we going to drive that blood forward? How are we going to carry the oxygen to the cells so they get what they need? So, cardiac assessment, I'm not nosy. I just like to gather information. I really do. I can tell my friends I should have been in the FBI, honestly. I like to find all the info. So, the first thing that we're going to do, not the first thing usually, but the first thing we're going to talk about is finding out the patient history, right? So in our SBAR, situation, background, we're going to look at their background. Presently, what's going on? What symptoms are they having? How long have they been going on? Have we done any interventions yet, given any medications? What about their past history? Have they had any cardiac diagnoses or other diagnoses that could affect our cardiac system? What about any surgeries, procedures? What medications have they taken in the past? I had a young guy come in one time, and he was in like his mid-30s, and he already had a pacemaker, and I was like, dude, that's some real poor genetics, it sounds like. And he was like, oh no, I took a lot of steroids when I was younger. I was like, well, that's good information to know. All right, good to know. So past medications, even if they're not on them currently, can still affect what's going on. Family history, so big with cardiac stuff, right? There's a lot of emphasis on it. That's one of those non-modifiable risk factors. So family members who have hypertension, coronary artery disease, have had heart attacks or any other type of cardiac dysfunction, stroke can be a problem. I feel like, does anyone have any family members who don't have any cardiac disease? I'm like, I don't think that's a thing. Everybody has family members with cardiac disease. It's just a given now. And then our social history, alcohol, THC, nicotine. I didn't put smoking because other forms of nicotine can be a problem too. I had a cardiologist tell me one time that he would prefer his patients smoke, which this is a cardiologist, I'm sure a pulmonologist would smack him for saying this, but he would rather his patients smoke than chew tobacco. Do you know why? So nicotine, it is a very, very potent vasoconstrictor. So it's gonna cinch those arteries up real tight, which is going to be a problem if you already have heart disease. So when you chew tobacco, I don't know if any of you have any or do or have any family members who do, but it gets stuck right down here in between your lip and your gums. So that buccal area, that's like one of the most direct paths to administer medications, right? Like when we give nitro sublingual, it goes in really quick. Anything there, so that nicotine is getting like directly into the bloodstream really fast. So that's, the cardiologist was like, that is causing more damage to my heart and the arteries than smoking. I'm like, well, your lungs will be a problem eventually. They all work together, but you know. So when we're doing our actual physical assessment, we're gonna look at our blood pressure. It's like one of our most basic hemodynamic measurements, a blood pressure, right? I also spent a little bit of time trying to figure out how to put sound clips in because I was gonna put in Queen under pressure. It didn't work, I'm sorry. I tried really hard to figure it out, but I had to keep going because, you know, it was late. Also, this is me. I can work calm under pressure. This is actual footage of me last night or this morning. So our blood pressure. How much pressure is that blood exerting against those arterial walls? How high is that? You have a systolic and a diastolic. Whenever you are checking a blood pressure, size does in fact matter, actually, contrary to popular opinion. If your blood pressure cuff is too big, you're going to get falsely low readings. If your blood pressure cuff is too small, you're going to get falsely high readings. Had a friend recently who was pregnant and going to have a baby soon, and they were really concerned about her blood pressure. Every time she went in the doctor's office, it was high. And they eventually sent her to labor delivery to be monitored. I don't want anything to do with that area. No, thank you. No babies. What was the other thing my daughter asked me last night? She's like, have you touched a heart? And I was like, not like a live one. I touched a cadaver one. She's like, oh, so you didn't like touch it while it's beating? I was like, no. She's like, well, have you ever like touched inside a body? And I was like, I don't know what you're asking, but I'm starting to get scared. I know, or a pathologist or coroner or crazy person, I don't know. We're trying to swing it in a positive way though. But she said, I said, I don't know what you mean. She goes like, put your arms in and get a baby out. And I was like, I don't want anything to do with babies. No. But I am proud that you know that babies come out. They don't come from a stork. So, but my friend went and they took her to labor and delivery and they put a blood pressure cuff on her that was too big. So when they were like, well, I don't know why the doctor's office sent you over here. Your blood pressure looks great. Psh, go home. Goes home, checks it on her cuff, which is the right size. Blood pressure is high again. So had they put the correct blood pressure cuff size on while she was in labor and delivery, they would have seen truly her blood pressure was too high. So, size matters. So we are going to check our blood pressure. We're going to check a pulse, right? Yeah. Pulse, we have a couple of components. We're going to check the rate. How fast is it going? What's a normal pulse rate? 60 to 100. Yep. It can be anywhere on that spectrum and can be lower or higher, normal for that patient, just depending on their age, activity, conditioning. My resting heart rate used to be 54 to 56 every day. Then I got COVID. My resting heart rate that was right before Memorial Day. My resting heart rate has stayed consistently in the 80s. And any activity, just walking, I'm like 130s. Man. Yeah. Healthy, young individual, and she's seeing a cardiologist, man. So viruses can mess some stuff up, especially some crazy weird viruses. Then our pulse rhythm. So is it regular or irregular? When you're feeling it, is it coming in regular intervals, regular beats? Do we got rhythm? Sorry, double checking my notes. So if our pulse is irregular and all over the place, we might listen and auscultate and count too while we're listening to our heart sounds to see how many beats a minute that is, because you can have a pulse deficit. So that's the difference between when you're feeling and counting their pulse out here peripherally and then apically. There can be some variations, especially if that heart rate is irregular. It's going to cause a pulse deficit. When the exam is too hard, you got to make sure you're still alive. I hope none of you do that during the certification exam. You're going to do great. But if you need a chuckle or a reset, just check your pulse. Think about that crazy lady who just kept talking to you. So I also was going to put Queen on the other slide, and then I was going to put Vanilla Ice on this one, because we're going to talk about listening to heart sounds. I was very disappointed. I had this all planned out. It did not work out like I thought it was going to. So heart sounds. Who can listen to patients' heart sounds and discern an S3, an S4, a gallop, a murmur? I can't. Usually I listen and I'm like, yep, it's beating. Here we go. The biggest thing for you guys especially is just knowing when something's abnormal and letting someone know. I keep thinking that's me, like my microphone. I had a really good friend, and he unfortunately was born with kidney issues at a young age, and so he had gotten a kidney transplant that failed. He was on dialysis, all these things, and his dialysis line got infected, and he ended up in my ICU at my other hospital. He was younger than me. He was in his early 20s, I think. And I go in, chit-chatting with him. He's getting lots of antibiotics. He's like, man, I just want to move out of the ICU. I'm doing better. I could go home, like not going home. But you're stable. You can probably move out of the ICU soon, I think. I do my assessment and I listen and I'm like, something sounds weird. And I hear this, when I'm listening to his heart, this grating sound, this rub. It's not that nice lub-dub. There's this rub in there. And I knew it wasn't right. I didn't know exactly what was going on, but I knew it wasn't right. And the nurse before me didn't say anything, which, she could have just been like, yep, it's making noise. But what he had was a friction rub. He had a pericardial friction rub, and his infection had traveled, and he had pericarditis, and he did not leave the ICU. But I knew something wasn't right. So even though we're not going to sit here and become experts today at discerning all these different types of heart sounds, just knowing what's right, what's normal, what's abnormal. Mary, did we test the volume on the computer?
I did not test the volume on the computer. I tested the volume on my microphone.
Well, we're going to test it now. We're going to listen really quick here to normal heartbeat sound. That S1 and S2. So our S1, that lub, is made whenever those AV valves are closing. And then our S2, dub, is made when those semilunar valves are closing, that pulmonic aortic valve. So those are what's causing those noises. If I can make it work, come on, man. Dang it. Okay. I'll make sure you guys get a link to the YouTube videos for this. Highly recommend. There's a ton of them on there. If you go on YouTube, just type in heart sounds. There was one on there that was an hour and 20 minutes long. It's a long time to sit here and listen to heart sounds. So S1, S2, those are from those valves closing. You can have an S3 or an S4. Like we're getting too involved here. I can handle two. Why we gotta keep adding in extra S's? An S3, that is what they call a ventricular gallop. So this can actually be a normal finding in kids and young adults, athletes, pregnant people. Whenever you hear it, they say it sounds like Kentucky. So instead of lub-dub, it's Kentucky. So there's like a little extra whoop on the end there with that ventricle. It is not a normal finding in older adults though, so that can signify heart failure or cardiomyopathy. An S4 is an atrial gallop, so that's Tennessee is how that one's supposed to go. This is not a normal finding in anyone, no matter what, and it is indicating heart failure. The reason you get that extra little sound is that blood is trying to be forced into a non-compliant ventricle. So there's maybe too much preload, too much afterload, but we're trying to shove something where there is no space and nowhere to go. So we're causing some extra noises. Murmurs, you can go down the rabbit hole with so many different types of murmurs. All I know is I hear a whoosh, it's not normal. That's what I need to know. They got a murmur of some kind, doc, you get paid to figure that out. But I can tell you it's not normal. And then we talked already about the friction rub, that little scratch noise. It's kind of like a grating sound. A lot of times indicating something's wrong with that pericardium. Maybe there's fluid in there, infection, like my friend, but it's gonna cause that rubbing noise. Do you guys wanna hear a joke about potassium?
Yes.
Okay. You're welcome. Just kidding, just kidding, just kidding. All right. Oxygen and potassium went on a date. It went okay. I'm done. I'm sorry. That's all I got. Common labs we're going to look at for patients if we're questioning there's some type of cardiac issue. Our electrolytes play a huge part in our cardiac function, right? We talk a lot about potassium. Potassium, it affects that nerve cell function. It's going to affect our muscle movement. It's going to help muscle contraction. So if it's out of whack, that heart muscle is going to become fatigued. It's going to get irritable. We're going to start seeing dysrhythmias and an unhappy heart. We want to try to keep that potassium in an optimal location, which is usually generally 3.5 to 5.0. Hyperkalemia, so it's too high. What kinds of patients would you maybe see a high potassium? Dialysis. Those end-stage renal disease, acute renal failure patients, that potassium's not getting excreted like it needs to. It's going to start building up. If we have a high potassium, we're going to start seeing on our EKG these tall peak T waves. That's not normal. The QRS is going to start getting wide. Then they're going to go into VFib. Then they're going to code. Then Mary's going to come running trying to help. So we want to try and keep that potassium in a good range. If it's too low, what can maybe cause a low potassium? Lasix. Yep. Those loop diuretics. Yep. People with excessive nausea and vomiting, diarrhea, so GI, uncompensated GI losses. Skin losses. People, which we don't get at our facility. I don't know if any of you have facilities that treat a lot of burns, but they're going to lose a lot of fluid. They're going to lose a lot of potassium. So when our potassium's low, what are some symptoms that we might see? Well, since it affects our muscle movement, we're going to start seeing some muscle cramps and weakness. We might start seeing some confusion in the patient. They also can end up going into VTAC or VFib because it's irritable that we're not keeping it in an optimal setting, optimal space. Magnesium. Magnesium doesn't get focused on as much as potassium. I feel bad for it. It gets left out a little bit. It just wants to feel important too, probably.
Who's been a nurse more than maybe 10 years? We never looked at mag.
Yay!
And now I feel like everybody's on. We have a hypo-K and a hypo-mag.
Mm-hmm.
And they treat it even on the lower end of normal here, which is just totally different to anything that I'm used to. When I went back to the bedside, I was like, what's happening here? Why are we looking at this lab?
Yeah.
Totally different.
It is. There's a lot of different focus, and a lot of physicians have different preferences. The hospital I worked at before I came here, the magnesium, their protocol, we kept it significantly higher than here. So I came and I was like, you guys, these mags are too low. And they're like, what are you talking about? That's fine. Stop it. I'm like, okay. A lot of physicians have different preferences, and depends on what's going on with your patient. But the magnesium, it's a necessary ion for energy production, that ATP those cells make and need and use. It's also going to help, just like potassium, regulate that muscle movement because it's going to act on their nerve cells. It's going to get on those nerves. If our mag is low, just kind of like our potassium, we'll start to see some muscle cramps, some confusion. Then we're also going to start having some irregular heartbeats. Do you guys know, maybe not, because I know this is not cardiac focus, but do you know what the one lethal cardiac rhythm is that's directly related to low magnesium? Anybody? Torsades. Good job, guys. Yes, torsades. So like a form of VFib, torsades is whenever you see that, we're going to give some mag. Usually their mag's low. You can also do this cool thing with patients with low magnesium, especially if it's really low, the Chove stick sign. Has anyone ever done that to a patient or seen it? I had a patient one time who it worked on, and I kept like bringing people in and showing them, and the patient got real irritated with me real fast. just trying to teach. So that's whenever you start to tap near their ear and their cheek will start twitching. It's going to irritate that muscle there. It's really, really interesting. So the patient did not think so and wanted me to leave with all my friends I kept bringing in. There's also something called a Trousseau sign. And so you get a carpal muscle spasm whenever we put a blood pressure cuff and tighten it on the upper arm. So it causes a spasm down here in this muscle. What are some things that might cause a low magnesium? It can be a few things. One big main culprit is alcohol abuse, diarrhea, poor diet, not taking in enough magnesium. High magnesium, not generally an issue very often. Don't see that a ton. But if you do have a patient who has a high magnesium, they're going to probably be fatigued. They're going to also have some muscle weakness. That heart is not going to contract as hard. We're going to be affecting that heart muscle directly. It's going to be fatigued. So we're going to have decreased contractility. They might start going into some AV blocks, which gets scary and confusing. They might start getting really sweaty. So, whoa, too far. And then the last electrolyte we're going to talk about specifically with cardiac function is calcium. We don't focus on this one as much. Kind of like how Mary said we didn't used to focus on the mag. We don't really focus that much on the calcium. It's still important. So if it's super out of whack, we'll jump in and, try to intervene. But I feel like it really doesn't get a lot, as it's not the star of the show like the potassium is. So a low calcium, it's going to cause muscle cramps and weakness. It's going to start causing some jerks, myoclonic, jerky movements can cause seizures, because that calcium is coordinating electrical signals to help with that muscle contractility. It also has a role in coagulation, which I found very interesting. Nobody talks about that. All right, cool. So calcium, it's also very important. We have some medications called calcium channel blockers, right? Whenever we interrupt that calcium channel, we're going to be interrupting this electrical activity, so that can slow down the heart rate. It's going to lower the blood pressure, all sorts of things. So those are electrolytes. What about other labs? Cardiac enzymes, they get talked about a lot, right? The quickest way to tick off a cardiologist is to check a troponin on a patient who has chest pain without talking to the cardiologist first. I swear, every cardiologist, I'm like, the patient has chest pain, I did an EKG, I got a troponin. He's like, can you not? I'm just trying to be efficient. Okay. So the troponin is one of those, is like the main first line cardiac enzyme we look at. It's the most cardiac specific enzyme that we have. So these enzymes, all of the cardiac enzymes, they break down in that myocardial muscle cell. So whenever that myocardium gets injured, it's going to start releasing these out, like warning and distress signals. So the troponin, it's the most cardiac specific because it is truly found only in cardiac muscle. Whenever we're going to see it spike after there's been some sort of a cardiac injury, could be usually within 3 to 12 hours of that injury starting. But one of the biggest issues is it's not eliminated very quick. It can stay elevated in the patient's body for up to 12 days. We like to sometimes trend those troponins out, depending on who the cardiologist is, trend those troponins out to see how severe, how high they get, how much damage is done, we can look at. It can be falsely elevated in some instances though, because whenever you see an elevated troponin, we think heart attack. That heart muscle has been injured, heart attack. But sometimes it might be high and the patient's not actually having an infarction. What do you think are some things that might damage that heart muscle, make that troponin start sending out warning signals? Trauma, yep. Pericarditis, not technically a heart attack, but that muscle is getting irritated from the friction from that pericardium. Cardiac interventions or surgeries. If a patient goes in for an open heart surgery and comes out, we've been messing around with all that muscle. So it's going to set off some distress signals. Pulmonary embolism, not a heart attack, but still affecting our heart. CPK-MB, so the CPK is creatinine phosphokinase. That is a muscle enzyme specifically. And MB is myoglobin, and that enzyme can be found in cardiac muscle and also skeletal muscle. So this can be useful when we're looking at a cardiac issue, but it's not always so cardiac specific like the troponin is. So we can see the CPK especially because it is just like a muscle enzyme. It's going to be elevated with other type of muscular injuries. Have you ever had any patients where the doctors are trending their CPK? Yeah. Patients in rhabdo, I've seen them look at it a lot. Yeah. That MB part, that myoglobin, that is more specific to cardiac. It's also skeletal, but we're really going to look at that with the CPK together to see, are we having some type of cardiac dysfunction? This can be falsely elevated in cocaine use. So we'll get a false positive that there's some type of heart issue with cocaine use. The troponin is not affected by cocaine. It's hardcore. But the CPK, MB, it is going to be elevated with cocaine use. It was in like my first 2 years of being a nurse. I had a 19-year-old come in with what looked like an MI. It was a STEMI. That EKG showed, I was like, 19? Now I got another thing to worry about. Add it on to the anxiety. Just keep pouring it in. One more thing to think about. She was using cocaine very frequently, and she ended up having a coronary artery spasm. So that artery was not functioning and damaged. It wasn't blocked like it is in a heart attack, but it still caused the end result of some damage to her heart, which is interesting. BNP, I think this lab is really cool, but it's unfortunate that it sounds so closely to BMP. You know, it's 3 in the morning and you're calling, trying to get orders, and the doctor's half asleep, or maybe they have their CPAP on. I'm not going to call out any of our cardiologists. It could be hard to hear what they're saying. This we look at very specifically with congestive heart failure. So this is a protein, the B-type natriuretic peptide, and the left ventricle is one of the main organs, main parts of our body that produces this. So when those fibers get stretched too much, it starts releasing that BMP out. So a normal BMP level is less than 100. 0 to 100 would be normal. Anything over 400 is pretty much indicative of CHF. That left ventricle has been stretched so much, it's starting to shower that BMP everywhere. So when you're looking at how severe someone's CHF is or initial diagnosis, we're really going to look at that BMP level. We also will trend it too when we're making adjustments to their medications to see how well are we helping their CHF. Is their BMP coming down? Is it going up? We need to work harder, figure out something new. And then ABG. We're like, well, we're talking about cardiac stuff. Why do we care about an ABG? It's respiratory. Our cardiac function is to carry that oxygen to our body. But a lot of things in that ABG can tell us if there's metabolic issues that could be affecting our heart, or vice versa. So we're going to look at that cardiac, that acid-base balance, and also it's going to give us information about that oxygen demand and delivery. Is our heart delivering enough oxygen to the body and meeting those needs? If not, we're going to start having some cell death, and then organ failure, and then body failure. No, that's no good. Okay. Common cardiac conditions. We're going to go through some stuff here. Now, I know on a med-surg floor, you probably aren't going to have patients admitted to you with these diagnoses, but you'll probably have patients who have a history of it, or they could be on your floor and then all of a sudden start having an MI. So just good to have a little background info here. So coronary artery disease, CAD, kind of a blanket term that we use a lot, kind of gets thrown around here and there. Really, the etiology is not super well understood, but we really believe that atherosclerosis is that main culprit, the main issue. There's going to be plaques in those coronary arteries and vessels. They can, and cholesterol, start to accumulate. They can rupture and go flying, clogging things up, cause a big occlusion, cause a roadblock there. So we need to open it up. We need to get that out of the way because the heart feeds oxygen to the whole body, but it needs oxygen too. So if its vessels on the outside are occluded, we're going to have problems. Biggest risk factors for coronary artery disease, usually high cholesterol. That is one of the biggest risk factors. We already said family history is big indicator. Hypertension, diabetes, lifestyle choices, obesity, diet, gender, women, because we don't have it hard enough already. Age, I already said diet, smoking, stress, ethnicity, African American, indigenous, people of color, unfortunately, again, don't have it hard enough already. Let's keep adding on here. So our treatment, we're going to open up that vessel. We can do that through PCI, so coronary intervention. We're going to put a little stent in, whoop, open it up. Sometimes they don't need to leave a stent. They might just do a little balloon, and that balloon's enough to get that vessel open and stay open. Usually they'll probably leave a stent in, though. We can do surgery, take them to the OR and do coronary artery bypass. I don't want any part of that either. No, thank you. That's too much. My daughter would be happy to hear, though, if I got to go, touch a heart, apparently. We can also do just medical management. One of the first times I had a patient come in with an MI, and I was like, well, aren't we going to the cath lab? We got to go. And they're like, well, we're just going to medically manage. The family doesn't want to do that. I'm like, I don't know what that means. We're in medicine. That means go to the cath lab. They're like, no. We're just going to be conservative. We can just give sometimes just some medicines, try to do conservative treatment. There's also clot busting medicines we can give. Tenecteplase, going to dissolve clots if a clot's the issue. We can give medicines to help dilate those vessels. So morphine, opioids, they're going to help open that up. Those beta blockers, the negative inotrope, also is going to dilate. Angina, chest pain. Biggest question, is it cardiac? Is it a cardiac cause? That is always like the most stressful part when your patient has chest pain. You're like, it could be 500 things and they're giving me chest pain trying to figure it out. Oh my gosh. Okay, so is it a cardiac cause? Because a lot of times we can have chest pain with lung issues, pleurisy, pleuritic pain, can have skeletal pain that gets misconstrued as chest pain. If you've had a patient who's had CPR done, they're probably going to start having some chest pain. And tried to explain that to a patient who coded one time. They woke up and they were like, oh, I'm having a heart attack, my chest hurts. And I was like, well, we did check you to see if you're having a heart attack because you died for a second. But your chest hurts because we were pushing as hard as we could to keep you alive, and it worked. So you're alive, but you're in pain. Sorry about that. Angina specifically, there's 3 different types you can have. You can have stable, unstable, and Prinzmentals. Again, probably some man naming something after himself. I don't really know how to pronounce it. But angina itself is, as a whole, chest pain that's going to be caused by reduced blood flow to the heart. We're not meeting that O2 demand that heart needs to continue to function optimally. It's one of our biggest symptoms of that coronary artery disease that we just talked about. Oops. Look at that guy. So he's really going to have some chest pain. So stable angina, this is, which when I first learned about this, I was like, stable chest pain, that can't be a thing. It's a problem, right? So stable angina, usually it lasts just a few seconds to a few minutes. It's something that's predictable. We know what triggers it. It's kind of a chronic thing that these patients live with, and they know, like, okay, if I go up and go up 5 flights of stairs, have some chest pain. I'm not going to be meeting that oxygen demand adequately. Apparently the weather can impact it. Okay, I'll blame anything on the weather. Stress, of course. But the biggest thing with stable angina is it's relieved by rest or nitroglycerin. It goes away. Not causing any other issues. Just an issue whenever it's triggered. The best way to diagnose it is doing a stress test. Has anyone ever had a stress test? Yeah. It's not fun. Yeah, well, Doug's the only male in this room, but, so, sorry. I had a stress test when I was like 22 because I kept having chest pain. Turns out it was just anxiety. But they took me in to do this exercise stress test because they're like, you're young, you're a runner, you're healthy, get on there, start running. But do you know what they did not let me keep on? Yup. I know. Very rude. And then I'm like, okay, I may be young and agile, but I'm not Houdini because I'm like running, trying not to pass out. My chest is for sure hurting now, and I'm stressed out, and everything's all over the place. And then they're like, okay. They're like watching my heart rate. They're like, okay, jump and roll onto the table so we can look. And I'm like, jump and roll? What? No, thank you. 0 stars all the way around. Not fun. So that's stable. Unstable, that's what it sounds like. This is going to be more severe, and usually this is going to be preceding an MI. It's going to last a lot longer than stable, up to 30 minutes or longer. It is going to be unpredictable. We don't know what triggered it. We just know it hurts. And we're going to see EKG changes. The pain's probably not going to be relieved fully with nitroglycerin or rest or anything else. It's only going to be maybe diminished if affected at all. So it's more stable, and that's our big warning sign. Something's going on, something's wrong. And then the Prinzmental, also called variant angina, this is just at rest. What this comes from is when those arteries start spasming. Those coronary arteries are having a spasm. If you're a 19-year-old taking cocaine, probably caused this. It happens without atherosclerosis because that other angina, stable and unstable, usually there's a little bit of atherosclerosis narrowing that road for the blood to get to those arteries. This, just the artery is spasming. Also tends to happen for some reason more so at night, which is interesting. But it's going to be relieved pretty quickly with nitroglycerin. Where are some common places that people have chest pain if they're having coronary artery disease? Yep, their back can radiate to their back. Below their sternum, have those people who say like, oh, it's just GI distress. So when I was here taking my CCRN review course, like all of you, knock on wood about this story, me and all my friends broke for lunch. I'm like, man, you hear that lady talking so much? I'm sorry, guys. I'm just trying to help. We went and we ate in the cafeteria. We never eat down here in the cafeteria, but we weren't here working. There was a group of us, so we all sat together, this big group of like 8 critical care nurses. We're chit-chatting, and all of a sudden I hear a lot of commotion, and my friend sitting across from me goes, oh my God, somebody's down. And I was like, what? And look over, and this poor volunteer in his cute little green vest is slumped over, and somebody's trying to pull him out of his chair onto the ground. I was like, man, that is the closest I've ever come to coding somebody outside of a hospital. I don't know if any of you have had to do CPR outside of the hospital. It's a scary, terrible, helpless feeling, especially being a medical professional. But we didn't have an AED down here. We did the next day, but go over, start doing CPR, all the things, put an IO in. The pulmonologist who was in for critical care that week was eating in the doctor's lounge. She comes out, Dr. Anthony, she's like, get an ER stretcher. We got him back, but it was a hot mess getting it going. But once everything cleaned, we got everything cleaned up, he went to the ER, we're trying to sit back down and eat our grilled cheese. We look over at the table where he was sitting, and there was a big unrolled thing of Tums, and Tums scattered all over the table. He was having chest pain, he was having angina, but he thought he was just having heartburn. He lived, thankfully. He went and he ended up with an emergent bypass, I believe, and he was on a balloon pump in the CVICU, but he did make it, which was really cool because it was real stressful, and I don't ever want to do it again. So I hope your lunch is not that eventful. In females, we know, again, it's not hard enough. Let's make things more confusing. But our chest pain, our signs and symptoms of coronary artery disease can be much different than traditional signs. So we might have that radiating to the scapula, down the back, all those different types of things that really don't scream heart attack initially. And it's easy to write off, right? I was having back pain the other day, and I was like, oh, I rolled that patient, my kid was running, and I'm trying to chase him. But then part of you, knowing too much, you're like, am I having a heart attack? Oh, I don't think so. Okay, I'm still here. So, other causes of chest pain, we talked about that a second ago. Sorry. We said pleurisy, pneumonia, bronchitis, anxiety, all the time. Cholecystitis, musculoskeletal strain, pancreatitis, all the things. You know that you can withdraw from beta blockers? I know that was a thing. You can withdraw from anything technically, but that can actually cause chest pain because those beta blockers, especially if they've been taking them consistently and chronically, have helped keep those blood vessels dilated. So if we take it away, they're going to start to cinch back up more than they're used to and start to have some pain, which is interesting. That was a fun fact for me to learn. Warning signs of a heart attack. Kind of just talked about a lot of this. Jaw pain, pain between the shoulders, can get lightheaded, trouble breathing, upset stomach, pressure in the chest, cold sweat, that feeling of impending doom. It's really, really scary. If a patient tells you something's not right, I don't know what, but something's not right, listen to your gut, listen to your heart. Other signs, women may feel very tired. I'm like, that's every woman every day. What? How do I get more tired than right now on 3 hours of sleep? They also might have heartburn, a cough, or some palpitations or appetite changes. So when we proceed to have an acute myocardial infarction, an MI, a heart attack, that coronary artery got so narrowed or blocked, something's interfering with that blood flow and that oxygen delivery to the heart. So also have like a blanket term of acute coronary syndrome, but that's the actual event of that heart attack going on. Clinical manifestation, we just talked a lot about chest pain. This is me every day. I don't always get a pain in my chest, but when I do, I'm convinced it's a heart attack. Do you guys have, who has an Apple Watch? Do you have the one that can, we did diagnose some Mary's post-COVID irregular heart rhythms on her Apple Watch. It's actually really accurate.
It's very accurate. It's only a one lead.
Yeah.
But it gives you 30 seconds, and you can print them in like 8.5 by 11. It's beautiful.
It's really cool. So whenever I start having chest pain, I'm like, okay. I'm okay, I think. I think I'm okay. It does have a little warning on there. It's like, it cannot diagnose a heart attack. I'm like, well, I'm diagnosing myself with anxiety. So chest pain. Also, we talked about women having atypical symptoms. Diabetics, too, have atypical symptoms. A lot of that sweaty back pain, shortness of air, nausea, fatigue. Whenever we do an exam, they're probably going to have an elevated blood pressure. They might be hypotensive, but typically their blood pressure is going to be elevated. When our body's under stress, all those enzymes and things, they get sent out and fight or flight, we're going to cinch up those vessels. Naturally what happens. Heart rate's going to speed up. Again, that fight or flight, that sympathetic nervous system is being stimulated. We're going to have some color changes in our skin, some jugular vein distension. When you listen, you might hear some of those abnormal heart sounds. Might hear some gallops or some murmurs or something like that. Whenever we're going to diagnose a heart attack, we're looking at EKG, what changes are on there. We're going to look at those cardiac enzymes that we were talking about. What about their history, their family history, all those things we went over. And then the true way to see it is to take and look in that vessel, look at that heart under coronary angiography in the cath lab. You can also look at a chest x-ray. I used to not understand, I'm like, why is like a chest x-ray in the chest pain order set? Like, they seem to be breathing fine. Okay, whatever. You can look and see what the size of the heart is. That can give us some clues, different things. And then also stress tests might help. Have any of you done the calcium score or have people do that calcium scoring test? It's getting more popular. It's kind of cool that they're using that as a predictor of heart disease, looking at that calcium, which is interesting. See, calcium is important. It gets left out. So how are we going to treat it? Medications, we're going to take them and open the vessel up, but we need to give them some medications before, during, and after that event. We're really going to be looking at anticoagulation. They're going to get probably some type of platelet inhibitor, aspirin, Plavix is a big one. Right now, Brilinta is like, according to all the evidence and trials and whatnot, that's our go-to antiplatelet drug. It also, the thing is, it's more expensive than Plavix. It doesn't have a generic, and it's twice a day. But all the patients who take it are shown to have better outcomes. We could also give patients heparin. We can give them IV infusions of some things called ReaPro or Integralin. We can do a lot of things to keep that blood thin. The fibrinolytics, so that's those clot-busting medications, tenecteplase or alteplase TPA. In our hospital, we have tenecteplase protocol if we need to give it for heart attack. It's kind of cool, but it's going to dissolve those clots. It's going to work in less than 30 minutes. Biggest contraindications do you think would be for that? Well, why would we not want to give someone a huge, big clot-busting anticoagulant? Prior bleeding. Yep. GI bleeds. Have they had a recent surgery? Recent CVA, recent stroke. Even if it's ischemic, why would we care? If it wasn't a hemorrhagic stroke, sounds like we'd probably help them, right? But that brain tissue and those vessels are going to be at risk for more damage. So we got to be careful with them. We're going to give narcotics, number one, to help with the pain, because that's our biggest symptom, right? But also we're going to decrease the workload of the heart. We're going to dilate, decrease that preload and afterload. Nitrates, again, that's going to vasodilate and decrease our workload of our heart. So the nitro, sorry, I totally lost what I was going to say. Do you guys know how they found out the erectile dysfunction drug worked? So it was originally formed for pulmonary hypertension, and whenever they were doing the trials for it, at the end of the trials, none of the men would give the leftover drugs back. And a nurse was like, well, why? And all the other researchers were like, oh, they kept it. And she's like, well, let's find out why. They found out that little side effect, and so now it's repurposed. Inotropic agents, so we're going to increase that contractility. If that muscle is damaged, it's not going to be working as hard, working as effectively. So we're going to give some medications, make it squeeze better. Antiarrhythmics, if we're damaging that tissue, We could be damaging the electrical system, might cause some problems through there. So if needed, give them some things, keep them beating regularly. Other vasodilating agents, we had talked about nitrates and whatnot, but beta blockers, we have already kind of touched on a little bit, going to dilate those coronary arteries, give lots more oxygen, blood flow. It's also going to help prevent extending that damage of that heart attack, especially if we're having trouble getting to the cath lab or opening that vessel or whatnot. It's going to help try to prevent that damage from getting worse. Sorry, looking at my notes here. And then PCI, our door to balloon time. We have goals, just like with everything. You know, CMS, they like to drive all the things. They make a lot of choices for us, but they have a standard, and American Heart Association says as well, we need to have those patients who come in with a heart attack have that vessel open within 90 minutes of them presenting to our ER, our facility, when their chest pain started, when they came in. Biggest complications, having an MI and after, mostly, post-MI dysrhythmia. Like I said, we've damaged that tissue. We could be damaging that electrical system. We're going to start having dysrhythmias. Usually we're going to monitor them in the ICU, especially if it was extensive. It's common to have an increase in temperature just because of the natural inflammatory process of those heart cells dying. Those heart cells dying are going to cause inflammation, and our natural inflammatory response is to have a fever. And then activity can be a big complication. Either they don't have enough stamina, or they don't want to get up and move, but they need to, because we need to keep healthy, we need to keep moving, but we need to try to encourage appropriate activity levels. I feel like we've all probably had a patient come down running around with or without a gown through the nurse's station. And cardiac rehab is going to help a lot with the activity level. All right, more questions. So we're going to have 2 questions after this. It's going to be about this scenario here. Geneva Curry, she's 65. She came to a medical telemetry unit. She was in the cardiac unit for several days because she had an MI. She's anxious and she has episodes of chest pressure. And since she's an anxious woman, we're saying that's why you got chest pressure, lady. So what is the nurse going to monitor her for closely? What common complication from an MI? Cardiogenic shock, cardiac tamponade, valvular rupture, or dysrhythmias, most commonly. Good job, guys. Dysrhythmia. I just realized you have your handouts now and you probably have the answer marked. These other 3 answers are possible complications, they're just not as common. So next time the nurse does vital signs, Miss Curry's temperature is up to 100.4. The nurse interprets this finding as evidence of pericarditis, evidence of infection, it's just from myocardial injury, or it's from dehydration. C, due to myocardial injury. And I feel like that's against our natural response. Anytime we have fever, infection, that's what we think usually, right? But it's just a natural inflammatory response sometimes. Okay, congestive heart failure. This is one we see a lot, right? A pump in a slump. So, heart failure, that heart is not able to move that blood forward for some reason. There can be a couple different types, different things that cause it. You might hear people say they've got right-sided heart failure, left-sided heart failure, systolic dysfunction, diastolic dysfunction. Whew, man, lots of problems. Biggest risk factors, hypertension, MI, sleep apnea. My husband, y'all, he will not go get a sleep study, and I keep trying to tell him horror stories of heart failure and heart attacks and all these things. He doesn't think it's that big a deal. Okay, but it really it directly affects things. It's scary. Diabetes puts us at risk for everything. Tobacco, nicotine use, different viruses can cause heart failure. The etiology with CHF here, we're going to have, you're going to have a couple of different things that cause it. So it could be from decreased flow, so a low preload. If they've got hemorrhage or dehydration, we don't have enough volume in there to stretch and contract. It could be from a high preload, increased flow, which I think we see a lot of. Big stretched out muscle here, getting big and floppy. That balloon doesn't want to snap back anymore. So sodium retention, water retention. Obstructed outflow, so that's that afterload we talked about. Narrowed arteries, high blood pressure, valve issues, that's going to start causing our CHF. Or if the heart muscle is damaged from an MI, it's not going to contract as well. If there's increased metabolic needs, fever, pregnancy, anemia, hyperthyroidism, not as common to cause heart failure, but still possible. So how do we know if it's right or left? A lot of times the symptoms are going to help tell us. So the right-sided heart failure, it tends to actually follow left-sided heart failure that's happened. But the blood from that right side isn't going to be moved through up to that pulmonary system into the left side, so it's going to start backing up systemically. We're going to start seeing systemic symptoms and problems. Sorry, put my notes in the wrong order over here. You're probably going to see, they can see some congestion in the liver, spleen, but you're going to see that pitting edema in those extremities, swelling in the legs and ankles, fatigue, loss of appetite, jugular vein distension. Yep. The left-sided heart failure. So this is going to be because that left ventricle isn't moving that blood out for us. Whether it's a contractility issue, an afterload issue, either way, that blood's not getting out into the aorta like we need to. So it's going to back up into the pulmonary system. So the symptoms we'll see from that are going to be reflected in their lungs mostly. Shortness of breath, dry, hacky cough, those wet breath sounds, paroxysmal nocturnal dyspnea. Sounds smart. Trouble breathing at night. Or it might be like positional, the orthopnea. Just like these little, a guy, he's struggling, man. Whew. Right-sided heart failure. I haven't heard that term in a long time, cor pulmonale. People will call it that much anymore. But, so the right side, we're going to see mostly systemic symptoms. The left side, it's going to be a lot of pulmonary symptoms. Systolic versus diastolic dysfunction. We said right and left, systolic and diastolic. So here's normal. Oh, look at that. The little heart working so pretty. Filling up with blood, ejecting it out. Everything's perfect. Well, in systolic dysfunction, the ventricles are big and floppy, and they're going to fill up with blood, but the heart is not going to be able to pump out as much blood as it needs to. It's going to be less than 40 to 50% ejection fraction. What's a normal EF? Do you guys know? It can be, they've changed it a little bit over the years, but they say now 55 to 75% of what's in that ventricle should be ejected, but it used to be like greater than 70, 75 was like the standard. I had a doctor one time, my patient had an echo, and I can't read an echo, but he went in there and he was looking at it, and I was like, what do you think his EF is? And he was like, what's your shoe size? I was like, this is weird. What? He was like, I think his EF's probably about what your shoe size is. I was like, well, that sounds serious. Good thing I didn't say Crystal's shoe size, because she got real small feet. But that ventricle, it's not going to be able to pump that out during systole. If we have diastolic dysfunction, so diastole, so those ventricles are going to be trying to fill, but they're going to be too stiff, or maybe that heart muscle grew inward. There's not enough space, but it's going to fill up with less blood than normal. So whenever the ventricle pumps, it's going to pump out 60 to 70%. That's a normal EF, right? We're not in heart failure. We're good. Well, you can pump out 60% of what's there, but if what you start with isn't very much, that's still a problem. So that's going to be your diastolic dysfunction. We've all seen this, pitting edema. My friends came to see me after I had my second child. I ended up having an emergency C-section. My labors were terrible. But they pounded me with fluid, just pounded me with fluid, and I had a lot of blood loss during my C-section, and I didn't really know exactly what went on, which is probably a good thing. But my friends, I was here, they were working, they came up to see me, come see the baby, and they saw my Foley, and they were like, there's a lot of urine in there. And I was like, yeah, they gave me a lot of fluid. And so my friend Alem, does anybody know Alem? I love Alem. She lifts the covers up and she's like, you have 4+ edema. And I was like, oh my God, I have heart failure. I just had a baby. They just gave me too much fluid. I couldn't keep up. Pitting edema, looking at an x-ray, you can see some pulmonary congestion, but look how big that heart is. It's taking up so much space. I know we're not trained to read chest x-rays, but that's a big old heart. That jugular vein distension there, backing up from that right side. We're also going to look at BMP, right? We talked about that. These patients are always going to have an echo. That is really our direct visual of how well that ventricle is moving that blood out. And that's also going to help us know what type of heart failure that they have. That's a terrible noise. With treatment, what are the biggest things we're going to focus on with these patients? When you're doing your discharge teaching, what do we want to talk about? What do we want to focus on? Make sure they know. We want to make sure they follow a good diet, which I think is probably the hardest part for most people to be compliant with. I mean, I don't blame them because all the good food has sodium, right? Sodium's going to attach itself and attract water. Medications. I always tell patients, I'm like, if you don't do anything else, just take your meds, please. Just do something for yourself. So those diuretics, vasodilators, we've talked about all these drugs already. Daily weight, also extremely important. How much weight gain would you tell a patient to report to their physician? Yep, 3 pounds in a day, 5 pounds in a week, significant. And then they could also get a pacemaker. If that heart is big and floppy, not contracting, or that electrical pathway has been interrupted by damage, they might get a pacemaker, get a defibrillator. A few other cardiac conditions. Valve disease. So mitral valve, it can do a whole bunch of problems. It can regurgitate, it can be stenotic, it can prolapse, cause a whole bunch of issues. Our aortic valve also can be stenotic, or it might have a bicuspid valve. The aortic valve, instead of having all of its leaflets, might have just 2. Biggest common cause of valve issues, endocarditis. That bacteria is gonna latch on to those valves. Have you ever seen an echo with a patient who has vegetation on their valve? It's scary. It's just flopping on there. And all of a sudden those little vegetation, those veggies are gonna break off and go traveling, cause strokes, whole bunch of problems.
Pop quiz, what's the treatment for that?
Mary knows because she's living it.
Q6-hour antibiotics for 6 to 8 weeks IV.
With her grandpa. See, I complain about being tired. She's real tired. So, rheumatic fever can cause this. Dental procedures. I have had, in my career, 3 young patients die from sepsis after dental procedures. It's scary. But that bacteria can get in directly, travel through that bloodstream, latch on, not go away. How are we going to fix it? We can repair it. We can replace it. We can manage it medically. usually anticoagulation. And if we do put a new valve in or repair it, we gotta anticoagulate them. It's a foreign substance. It's something, especially the mechanical ones. This is some type of tissue, cow, pig, something. But those mechanical valves, they have to be anticoagulated. They cannot miss that. Otherwise, we're gonna have a whole host of problems because that body is gonna form clots and stick to it. So, endocarditis. We just talked a little bit about that, talking about the valves. All of this bacteria, vegetation, getting in there, latching on where it can. It's really gross. I don't recommend Googling pictures of endocarditis at 3 a.m. It's gross. Causes, we just kind of talked about them. Rheumatic, fever, dental work, IV drug abuse. See that a lot. How are we going to fix it? Well, we're going to manage the symptoms, but Mary is the IV antibiotic queen now for endocarditis. Manage our symptoms, oxygen, just give them supportive therapy. It's really all we can do. Has anyone ever had a patient in cardiac tamponade? Man, they sure like to use it on TV though, Grey's Anatomy. They're over there aspirating pericardiums with a pencil or sonic straw. Not real life, but that heart, for some reason, we have that sac that's protecting it, that pericardium. It has a little fluid in there to cushion it. For some reason, that fluid has expanded or is infected. Something is causing pressure onto the heart, and it's mad. It's a problem. When you have a patient in cardiac tamponade, the symptoms you're going to see is called Beck's triad. Merck's triad. It's funny. He's being squeezed. So that's muffled heart sounds. It's going to be hard to hear because that pericardium is covering all of that. They're going to be hypotensive. We're going to have trouble with our stroke volume because the heart's not going to have enough space to contract and expand like it needs to. And they're going to have distended neck veins because that fluid that we're not pumping forward is going to start backing up into our system. Really the only way to fix it is to get that fluid out of there. And if it's from an infection, give them antibiotics, but have to aspirate fluid, try to keep it away. They'll do a pericardiocentesis. If it's recurring, you can do a pericardial window, which I think would be cool to see. These patients, you'll also see, it's not in Beck's triad officially, but get really tachycardic. Like really tachycardic, because that heart's trying to compensate for that low stroke volume that's happening. Vessel diseases. I feel like these precede a lot of cardiac issues. Most commonly, four most common ones, arteriosclerosis, atherosclerosis, aneurysm, and peripheral vascular disease. So arteriosclerosis, what it sounds like, that artery, for whatever reason inside there, it's decreased in size. Can happen for a lot of reasons, but biggest risk factors are age and a high-fat diet. That cholesterol is going to start building up and taking up that space. It's going to cause some hypertension. Aneurysms can also cause heart attacks eventually. Atherosclerosis is when we start building up plaques formations. Plaques start forming because there's been endothelial injury in that artery, in that vein, in that vessel. Biggest risk factors to injure your endothelium: age, smoking, always, every time. Just if there's a question on the test that's like, what are risk factors? Age, smoking, high blood pressure, diabetes, but it can cause TIAs, so mini strokes. If those plaques start rupturing and breaking off and shooting around, they're gonna go get lodged in our brain, cause little mini strokes. Can also cause tissue infarction in other places. If that plaque is blocking an artery, somewhere, we're going to start having problems getting blood flow there. Aneurysm. These stress me out really bad. I get really nervous. And they can be stable. There's a lot of different types. You can have aortic, cerebral, ventricular, abdominal, we're aneurysm all over the place. It can be stable, which always makes me nervous. I'm like, this does not feel like a stable thing. But a lot of times, especially the abdominal aneurysm, they'll monitor it, make sure it's not growing, try to keep the blood pressure under control so we don't expand it. But they form because those arterial walls are weak and thin and we start to get bulges out of them. 35th leading cause of death. You think there's somebody somewhere just every day counting the cause of death, tally marks, oh, sepsis is still in first. Yep. If they are starting to have trouble, if it's expanding, if it's dissecting, if it bursts, emergent surgery. But we want to manage that blood pressure and keep it low so we don't cause any further injury, issue, or damage.
You want it more lower than what we need to normal? Do you just want to try and keep it normal?
It depends on the patient and how severe and how big it is, but really the lower side of normal, and if hemodynamically they can tolerate it below that, systolic of 100, we still want to perfuse. So does anybody know the minimum MAP, mean arterial pressure, to perfuse all the things, specifically your kidneys, because they get hung out to dry first when your blood pressure drops? 65. Yep, minimum MAP that we want to keep to perfuse, especially our poor little kidneys. Otherwise, you'll end up on 11th floor.
I'm going to give you about a 10-minute warning. I know you started late, but I just want you to have an idea of where you are.
Thank you. Peripheral vascular disease, I think we've all seen these patients, right? They come in with the brown, discolored, pinkish discolored legs down there. Do you know where that discoloration comes from? Because that blood is pooling and it's not moving, the iron in that blood causes that discoloration. Very, very bizarre. But a lot of things can be classified as peripheral vascular disease. But biggest risk factors, smoking. Please don't smoke, everyone, if we've learned nothing today. Trauma, hypercoagulability. The best way to prevent and treat vessel disease is reducing the fat intake. Less than 30% of the daily calorie consumption should be from fat. Our goal cholesterol level is less than 200, and our goal LDL, so the bad one, right, less than 130. Our HDL, so the good one, greater than 35. Okay, last couple things. Dysrhythmias, AFib. Again, I wanted to put a little sound clip in here. Some Janet Jackson, didn't work out. I just keep telling you guys what I hope to do, sorry. All right, cardiac conduction system. I'm not gonna go through the whole thing. You don't need me to read to you, but the heart has its own pacemaker, its own conduction system, and it follows a very specific pathway. And any interruptions in that are going to cause some dysrhythmias. A normal rhythm, normal sinus rhythm, it's going to be regular. Here's a little breakdown of what all of our little spikes and bumps and humps mean. Also tried to explain this to my 8-year-old. It didn't go far, but we're trying. Keep getting there. So our P wave here, the PR interval, I really like this animation because it shows you where in the cardiac cycle it is. But this is going to be our atria depolarizing. Our QRS, the big one, that's those ventricles depolarizing, which makes sense because the ventricles are like the powerhouse. They got to squeeze the hardest. So it's going to be the big tall one here. And then our ST segment is that ventricle. It's that repolarization refractory period is what it looks like. So got a small little hump is your P, then a negative deflection is a Q wave. Q waves are not normal. Those occur after heart attacks usually, or some type of cardiac injury. So seeing a Q wave, it typically means the patient has had some type of cardiac injury. The R is the tall peak, come down, S, and then your T is your next little hump after that. So normal sinus rhythm, there's going to be a P wave in front of every QRS. It's going to be regular, come in at the same time. It can keep rhythm. It's got a good beat. It's going to be 60 to 100 beats a minute. Sinus bradycardia are all those things except it's just slow. It's still going to have a P wave, still going to have regular intervals, but it's just going to be really slow, less than 60. If they're symptomatic, we're going to want to treat them. We have ACLS algorithms for that. We're going to maybe give them some atropine, might pace them, all sorts of things. If they're not symptomatic, sometimes we just monitor it. It depends, might be normal for a patient. My brother-in-law, he's real small and scrawny, he's in the Army, he's very active. My sister, I was visiting him, she was like, he was sleeping on the couch, she's like, go check his pulse. His heart rate was 30. And I was like, we need to go to the ER. She's like, it's always like that. All right. Sinus tachycardia, again, same as sinus rhythm, it's just fast, greater than 100. There's going to be a P wave for every QRS. It's going to be regular, but going to be greater than 100, 100 to 150. Faster than 150, we're going to call it something else. And sinus arrhythmia. This one is the one that's kind of confusing. And I feel like it ends up being like a catch-all term sometimes. Like if you can't figure it out, be like, it's sinus arrhythmia. So there's going to be a P wave with every QRS. And mostly it's going to be regular intervals, but you just might have a little bit of a irregularity in there. It's seen a lot in pediatric patients. It also is going to be 60 to 100. So it's a normal sinus rhythm, but then you just have a little arrhythmia irregularity in there for whatever reason. Atrial arrhythmias, AFib, that's one of the big ones to know, right? We know our sinus rhythm, AFib, because a lot of complications can come from AFib. Those little atria up there are just sitting and quivering, not fully squeezing and contracting and pushing that blood down into the ventricles. So if it's just sitting there quivering, what's going to happen? Clots. That blood's going to start pooling. Also, we're going to have a decrease in our preload because we lost our atrial kick. We lost that squeeze. So not all that blood came down. So that's going to affect our cardiac output. AFib is always irregular, always, and there's no defined P waves. Little squiggles, QRSs, here, there, and everywhere. Can be caused by so many things. And sometimes patients are stable, but other times, if their heart rate's greater than 100, we say they're in AFib with a rapid ventricular response, AFib RVR. We're going to want to give them some antiarrhythmics to help with that. A-flutter, I think this rhythm's so pretty. Little sawtooth patterns, like it's just beautiful. So instead of quivering, the atria are up here just fluttering around. Sorry. It can be regular or irregular. It's interesting when it's regular. But yeah, the biggest thing, we want to control the rate. Try to convert them if we can. Cardiovert them if they're really being impacted by it. But that anticoagulation is the biggest thing we want to do. Make sure we're not causing any further damage with clots flying all over the place. Heart blocks. I don't anticipate you guys are going to have to interpret some super in-depth heart blocks on your exam, but knowing heart blocks are bad, okay? I think we all know, but issues in the conduction through that electrical pathway causing delays. A first-degree AV block looks very similar to a sinus rhythm. There's just a delay between the P wave and the QRS. It's longer between the atria depolarizing and the ventricle depolarizing. A second-degree type 1, it's also called Winky-Bach. That's a fun one. So this one, your PR interval, so where your, this is a really bad strip, I'm sorry. where your P wave comes in relationship to that big QRS spike is going to change. And it's going to progressively get longer and longer until all of a sudden we have a P wave with no QRS after it. It just didn't come. I don't know where it went. So they say longer, longer, longer drop. Now you have the Winky Bach. So that's type 1. Second degree type 2, it's usually the type 1 looks irregular because of that progressive lengthening out sometimes. The second degree type 2, there's always going to be more P waves than there are QRSs. But it's going to be regular. So see, we have the little P wave, there's a QRS, we have another P wave, and it's missing its friend. The third degree AV block is the most serious, so I think that's probably the best thing for you guys to know instead of memorizing all the ins and outs of the rhythm. Third degree AV block, your atria and your ventricles are not talking to each other anymore at all. And it's going to be going real slow. So those patients are going to need intervention pretty quickly, usually a pacemaker. Life-threatening arrhythmias. VTAC. It also is pretty little sawtooth pattern here. That left ventricle, that signal is just whoop, 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 flopping around in there. You can have VTAC with a pulse. You can also have VTAC without a pulse. But you're going to have a big, wide, bizarre QRS complex. It's going to look very regular. If they have a pulse and they're conscious, if they're stable, we'll give them antiarrhythmic. But if they're unstable, we're going to cardiovert them. If they don't have a pulse, we're going to start compressions. VFib, they will never have a pulse because it is just fibrillating. Nothing is happening here. So squiggles, 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 chaotic, irregular, high quality CPR, and the most important thing, especially for both of these, VTAC and VFib, pulseless VTAC and VFib, early defibrillation. Shock them as soon as possible. Asystole, that's the easy one. If you have any rhythms, I hope it's this one. Easy to identify. PEA, pulseless electrical activity. You could see spikes on here, but they're not going to have a pulse. It could look like a normal strip, but they won't have a pulse. Again, CPR. All right, until I run out of time, quick questions. Herbert Chang, he's 64, he's diagnosed with heart failure, he had an MI, he got transferred to your unit, he's on lisinopril, Lasix, potassium. What do you want him to report immediately? Shortness of breath, urinating frequently, diarrhea or nausea? Shortness of breath, yep. Especially depending on where that MI was, it can cause some damage and cause some pulmonary issues. You're going to discharge them. What are you going to reinforce the importance of following? Daily weights? Yep, daily weights. Make sure they know weight gain, 3 pounds in a day, 5 pounds in a week. They need to see the doctor quickly. If the RN recognizes that a patient is at risk to develop endocarditis if they have what? What will make them at risk for that infection in their heart? B, valvular disease. They like to catch on to those valves. I know I have no time. Questions? Do you guys know Kid President? I love him. If you do have questions or want to chit chat, my email's on there. Please feel free to reach out. My friends know how to get a hold of me, but you guys are all going to do great. Sending you lots of encouragement and moral support. I'm rooting for you. You're going to do wonderful.